Hello guys, hope I'm audible and visible. A very good evening. So welcome to one more session on YouTube where we are going to discuss few more questions, whatever we have left in the 7 p.m. session with relation to GIT, and a few questions maybe to liver with start with. So in the previous 7 p.m. discussion, we had quite a few doubts there. One was the molecular classification of gastric cancer. I'll talk a little bit about that. The gross difference between a benign and a malignant ulcer. We'll have a look at that comparison as well. And also about the various colonic polyps, the microscopy, the villous adenoma especially, how to differentiate villous, Peutz-Jeghers, juvenile or serrated adenomas, right? So initial part of the discussion is going to be that. We'll cover whatever doubts we had at 7 p.m. session, and definitely we'll cover a few more MCQs regarding GIT and liver as well. Hello Rasa, I'm good. Hope you're doing good as well. Fine. So start with, I'm sure you must have been updated about the March sessions. Like I said, that April will have the free test daily as well as 2 GTs maximum, right? So that if you have time, please go through it. Hello engineer doctor, and your previous year question bank is available for you. I've recorded a video. I'll definitely share it with you guys how to access the question bank. If possible, I'll just have a quick demo here as well. See, if you have an Unacademy thing, if you open that, see, you have home, you have syllabus, and if you go to the test icon, you click on any subject, right? If you click on any subject, you'll have the previous year question bank here. Click on that start. Automatically based on the questions, year-wise questions, it'll be segregated, right? So hope this helps you to access the questions. If you still have any trouble, you can contact me at any point of time. I'll be able to help you guys. Fine. Hello Samir. Okay. And Unacademy Lite is a subscription, is only for subscribers who wants only the content of tests and question bank without videos. If you want to enroll to any one of them, or including the plus subscription, you can use any code you have. If you don't have a code, you can use PathoCups. Fine. So to start with, if you're a subscriber, you can enroll to any of these batches which you deem fit. Fine. So as I said, to start with, the first focus is going to be on a difference between a benign and a malignant gastric ulcer. What we saw in today's class was the image below this, right? The second image what we saw here, where we had a question of an patient with an I'll tell Chakravarti, patient with a melena, and the answer was most of them can be easily treated, right? Then I said that there is no heaped up margins, right? If you can see that here, this is a necrotic bed of the ulcer, and you can see the mucosa almost reaching to the edge of the ulcer, which means there's no margin heaped up. I'm having a shallow ulcer here, that's an ulcer, and obviously the mucosa is reaching till this, which means at the edge there's no heaped up margins. So what do we mean by heaped up margins? Let's assume this is a normal peptic ulcer or a gastric ulcer. So again, I'm having a normal mucosa here. Let's assume this is the ulcerated part. When I say heaped up margins, this part will overgrow. Okay. When this part overgrows, I'm going to call it a heaped up margin, right? So the margins get heaped up. Am I right in saying that this mucosal rugae might not reach till the edge of the ulcer? It will stop here, right? It should stop here because I'm having a heaped up margin, right? That is a very, very characteristic finding in the gross finding or endoscopic finding of a malignant gastric ulcer, right? So if you look at this image, the one on the top is a malignant gastric ulcer and is a benign gastric ulcer. I'm sure you can appreciate this margin here. This is definitely heaped up. It's kind of protruding from the edge. That's a heaped up margin. That's how it looks in a malignant gastric ulcer. And I hope you will not have any more confusion. I'm sure you must have read lots of barium signs regarding benign and malignant gastric ulcer. The lines and the signs, those are also important for exams. If you are preparing for an exam, please do have a quick idea about your radiological signs of benign and malignant gastric ulcers as well. Fine. Chakravarti, I'll take a detour from the routine thing and I'll try to answer your question. How to revise pathology? See, path is one of the easiest subjects if you understand the subject, right? The only problem for us is we always try to read them as general pathology, systemic pathology, and hematology. We do not kind of merge them. You have to merge them. Once you merge them, definitely it's very, very simple for you to revise, right? So what do you mean? What do I mean by merging is, let's take general pathology. You have your cell injury, your necrosis, apoptosis, inflammation, genetics, and neoplasia. Only these 5, right? So I want you to remember this 5 and apply this to every organ system. It's taken care of. The only problem for me is I am reading inflammation every time, every organ system. I'm not applying what I'm reading in general pathology. Please link. The easiest way to read pathology is link general pathology to systemic pathology, link general pathology concepts into your hematology. Those are concepts. I read one and I can apply to almost every page of Robbins. Same inflammation. If it is CNS or in the great toe or in the little toe, inflammation behaves in the same way. That's all. So if I know the general concepts, I can easily apply to that, and revision will be very, very simple. This for everyone who wants to revise. Whenever you revise for any subject, right? Not just pathology. I'm just going to erase this. Sorry for the detour. I'll definitely continue with the gastric molecular classification and the polyps soon, right? Whenever you want to revise any subject, I want you to keep this in mind. I've read it once, right? After reading a subject, let's take that I have made an 200-page notes. Fine. I read it, let's say 3 months back. I'm having a 200-page note. I'm going to revise for the first time. The advantage of revising twice or thrice is I can filter out what I'm going to revise in first reading, second reading, and third reading. During the first reading, the only thing I want you to do is color code things. It will make your life much easier. Green, red, and yellow, that's all, right? So when I color code something as green, which means I already know this topic, I'm not going to revise. I'm not going to waste time on that. For example, in general pathology, I'm sure all of you must have known about necrosis. The most common is coagulative necrosis, caseous necrosis, tuberculosis, and liquefied necrosis brain. Don't revise that. You already know that, right? So those are to be green color coded. Yellow is somewhere which I know about the disease, but I'm not sure about it, which means I want you to read it. During the first revision, the only goal is to change all yellow into green. So red is one which are scary topics for me. I don't know about it. Again, the purpose of first revision is to change red to yellow. The second revision, again the red should go back to green, right? So the third revision, almost everything gets streamlined. This is the way to revise always, right? The first revision is to make sure I'm not going to touch this topic again. If you are so comfortable with ECG of myocardial infarction, keep it in green. Don't read that again, fine? That should be perfectly, it should be like that only, right? So that's how you color code things, and if you are able to revise in this way, it will be much useful for you, fine? Okay, coming back to the subject. So now we have seen the difference between a benign and a malignant gastric ulcer, right? Okay, just give me a second. Okay, so regarding the molecular classification of gastric cancer, this is kind of a new thing, right? The new edition of Harrison, this image is from the new edition of Harrison. So what has happened over the period of years is every cancer is being redefined based on the molecular basis. If you remember the older surgery books, you must have started with the gross classification. That's almost gone. Latest one you must have read is Laurent classification, where it divided something as intestinal type and a diffuse type carcinomas, right? The latest one for gastric carcinoma is the molecular classification of gastric carcinoma. There have been no questions as of now regarding molecular classification of gastric carcinoma. If something comes in future, you should be able to understand that. There are 4 subdivisions. I'll tell you a few important points regarding every subdivision. If you remember, there are 4 and few important ones, which is most common. What is the response to treatment? That should be more than enough. These are the mutations there. There are n number of mutations. If you see there are many mutations here, right? It's very simple for us to remember this because we already know this information in bits and pieces. One of the classification which came in Laurent was the diffuse type of gastric carcinoma, which is familial. We had an MCQ as well, which is your CDH1 related, right? CDH1 is an E-cadherin loss. So when CDH1 is related, we call them a genomically stable cancer. The reason why it's called genomically stable is, can any one of you say what is the function of CDH1 gene? What is the function of CDH1 gene? I'm sure you know the function of CDH1 gene. The function is E-cadherin, right? They secrete E-cadherin, right? So CDH1 has nothing to do with genetic stability. Even if it's mutated, the gene will be stable. In other words, on the other side, if you have a look at this, it's microsatellite instability, right? It's a methyl mismatch repair. So if I have a methyl mismatch repair defect, am I right in saying that the genome will not be stable? So definitely there'll be no stability, right? So the methyl mismatch repair defect will come under genomic instability. Again, when you go to chromosomal instability, when I say P53 is mutated, am I right in saying that the errors in the DNA replication will not be sorted? Definitely, right? The errors in the DNA replication, if it's not sorted, definitely the entire chromosome becomes unstable. So this part is definitely unstable. This part is definitely unstable because we know the function. So CDH1, as Dipti said, that it's an E-caldron. It produces E-caldron. There's nothing to do with genomic stability, right? So genomically stable group is something which is not going to interfere with DNA repair mechanisms. And obviously you know this as well. One of the commonest virus seen in gastric carcinoma is Epstein-Barr virus. H. pylori is a bacteria that's totally different. Epstein-Barr virus is one of the commonest one, and there's been lots of emphasis going on in Epstein-Barr virus because in viral related cancer. So I'm looking forward in future, if I am able to prevent the virus, I can reduce all the incidence of that, right? So that's the focus for us. These three I cannot reduce because they are genetic mutations. It's difficult for me to reduce, but this entire chunk I hope that I'll be able to reduce in the future, right? So these are the 4 different types of molecular classification of gastric cancer. Again, it has a little bit of importance. This is the most common subtype. You need not remember that again, you already know. Which is the most common gene mutated in every gastric cancer? I'm sure all of you know that question, answer to the question. The most common gene mutated in every gastric cancer is going to be P53, right? So a type which definitely has P53 mutation will obviously be the most common, right? It amounts for up to 50%. The chromosomal instability type of cancer amounts for up to 50% of the gastric cancers. Majority next will be this MSI instability, approximately 22%. Rest is between my EBV and my genomically stable. EBV is actually the least important, like it's around 10%. Just 10% of the cancers are EBV related in the molecular classification. What makes a difference here is, apart from a genomically stable, rest everything, all 3 of them will have intestinal type morphology only. They will not have a diffuse type of morphology. Only the genomic stable type, which has CDH mutation, will have the diffuse signature type of gastric carcinoma. The location has a change. Like genomically stable and my microsatellite instability doesn't have any particular location. On the other hand, EBV positive tumors are most commonly seen in the fundus or the body of the tumor or the body of the stomach. That's the location of the EBV positive tumors. And when it comes to your chromosomal unstable tumors, most of them are seen in the gastroesophageal junction. They are close to my JE junction and the cardia. Again, these are the predominant location. Doesn't mean that it will not happen in the rest of the body. It can happen in the rest of the stomach as well, predominantly in these places, right? Again, the only goal of molecular classification, whatever it is, if I'm going to classify molecular classification of breast cancer, my goal is prognosis. I'm going to target the therapy and I'm trying, is there any targeted drug available for me to treat the patient, right? Here also you have multiple mutations there. Here JAK2 has a targeted mutation, you know that. PDL1 has a targeted therapy, you know that, right? Almost everything here can be targeted. The only difficult thing for us is your microsatellite instability. They do not respond to any adjuvant chemotherapy, right? So here the response to chemotherapy is very, very less. Okay. So which means primarily I'm going to go ahead with the surgery, because if you have read surgical management of gastric cancer, what you must have been told is neoadjuvant chemotherapy, reduce the size of the tumor, then go ahead with surgery. If it is microsatellite instability tumor, it will not respond to chemotherapy, so go ahead with an upfront surgery. So these are the informations which is present as of now. It's a very, very new classification. These facts might change in future, right? Because if something is new, I might have if there's any advancement regarding the prognosis or more targeted therapy coming in future, it will definitely change, right? As of now, in Harrison, these are the informations given for you, and if it comes, it will be great, right? Okay. We'll go to the third part of the doubt. What we had in today's class was the different types of intestinal polyps, how to differentiate them and how to identify them based on a microscope, right? So I did talk to you about the theoretical aspect. I'm just going to ask you again. I want you to answer it. Fine. Let's say that when will you call something as in villus adenoma? When will you call something as in villus adenoma? What is the percentage of villi to be present to call something as in villus adenoma? That was a basic thing which we discussed in the class. Okay, the different types of polyps. We have tubular adenoma. Okay, we have villus adenoma. We have Peutz-Jeghers polyp. We have juvenile polyp. And we have serrated adenomas, right? So these are the 5 different types of adenomas which can happen in an intestine. Hyperplastic polyp, I'm not going into much in detail. I'll have a passing mention about hyperplastic polyp as well. Perfect. Samrit, I told if it looks like a 100% villi, go for that. But as per definition, it's going to be 75% only, right? Just for our ease, for identification, I told you that if any of the tumors has more than 75% villi, I'm going to call it a villous adenoma. The same tumor has less than 25% villi. See, tubular adenoma is not graded based on the amount of tubules. It's graded based on the amount of villi only. It's less than 25%, I'm going to call it tubular. More than 75%, like you guys said, I'm going to call it villous. In between, 25 to 75%, we call it tubulovillous adenoma. Again, it's not required for us, fine. Come to Peutz-Jeghers polyp. See, when I say Peutz-Jeghers polyp, all of you know that it's like a Christmas tree, like an arborizing polyp, right? When we look at the Peutz-Jeghers polyp, I'll give you a reason why it looks like arborizing and why we call it hematomatous as well, fine. So Peutz-Jeghers polyp, like you guys said, most of the Peutz-Jeghers polyp will be pedunculated. They'll not be sessile, they'll be pedunculated, which means they'll have a stalk. Peutz-Jeghers polyp, the way to identify is, you'll have the muscle layers between glands. Okay, when you have muscle layers between glands, again not in the stalk, you have to be very, very careful in identifying that. Let's assume that this is my intestine, the flat mucosa of the intestine. I'm having a stalk here, and then I'm having a polyp here, right? In this stalk, for any polyp, be it Peutz-Jeghers or be it tubular, whatever it is, this stalk will have muscle because stalk is made of muscle, right? So this muscle, I should not mistake it for Peutz-Jeghers muscle. In Peutz-Jeghers polyp or a syndrome, Peutz-Jeghers syndrome, what will happen is the muscle will be seen here. When I'm going to see muscle in the substance of the polyp, I'll call it a Peutz-Jeghers syndrome, not in the stalk. In the stalk, for every polyp here, if it has a stalk, if it's pedunculated, you will have muscle, right? That's the only difference. Don't overthink and call a villous adenoma because you see a muscle as a Peutz-Jeghers polyp. It should be between the glands. Glands is one which you can easily pick up, so definitely you won't have a problem. Juvenile polyp, like we saw in the class, juvenile polyp is an mucus retention polyp. So you'll have cystically dilated mucin secreting glands. It's a mucus retention polyp. So you have multiple glands with insufficient mucin inside them. That's obviously how a juvenile polyp looks. Serrated adenoma is simple. Again, what we saw was the reason for serrations also we saw. We also saw if the crypt is going to proliferate more, I'll have crypt distortion, right? Those are two things here. I will have serrations as the name says, then my crypt will be distorted. For an undergrad, I would say that concentrate more on crypt distortion because in bit of an easier thing to pick it up rather than my serrations. Serrations are prominent, you can definitely pick it up, otherwise it's a bit difficult, right? So these are the 5 different things. I'm going to show you all the 5 microscopy. I want you to comment on what you see, fine? Simple, look at villi, more than 75% villous, less than 25% or no villi, tubular. Muscle between glands, Peutz-Jeghers, dilated glands, juvenile, and serrations and distorted crypts is going to be serrated adenomas, fine? So what do you think this is? We'll go step by step. Are you seeing villi in this image? Yes or no? Just comment yes or no. So definitely we can come to a conclusion. Is villi present here? Villi is not there, right? So if villi is not there, villous adenoma is ruled out, right? So I'm having lots of glands here. In between the glands, do you see muscle fibers? There are no muscle fibers, right? So again, if there are no muscle fibers between the glands, definitely my Peutz-Jeghers polyp is also ruled out. So the only options for me is tubular and juvenile polyp or an serrated polyp, right? Serrated adenoma. There are no serrations here. I am not seeing any crypt also. So serrated adenoma also ruled out. So I am kind of stuck between two things. Tubular adenoma versus juvenile polyp. The only difference is in a tubular adenoma, it will be tubules. Tubules are nothing but tiny glands. They are very, very, very tiny glands. Here in this image, you are seeing dilated glands or tiny glands. Definitely all of you will agree that in this image, you are seeing multiple dilated glands filled with mucin, right? So definitely the answer here is juvenile polyp. Okay. So it's easy algorithm based. Villi is seen or not? If villi is not seen, look for muscle. Muscle not seen, again it's glands. Tiny glands, dilated glands, tiny glands tubular, dilated glands is going to be juvenile. Serration seen, serrated adenomas, that's all, fine. We'll use the same algorithm for all the rest of the images and we can easily identify what it is. We don't want the history, we don't want the age, we can still identify based on microscopy alone, right? Okay. Are you seeing villi in this image? The same algorithm. I'm not going to change my algorithm. You are also going to use the same algorithm to diagnose polyps. Is there villi here? There are no villi, right? Are you seeing muscle between the glands? Are there prominent muscle in between the glands? There are no villi here, but I can see definitely prominent muscle in between the glands, right? So this is my muscle. You can see the muscle layer where I am putting dots. This is also a muscle, and obviously all of you will accept that these are glands, right? I'm seeing lots of muscle in between the glands. Perfect. So it's an Peutz-Jeghers polyp, right? It's simple identification, that's all, right? So you have glands and you're seeing muscle in between them, it has to be a Peutz-Jeghers polyp. As I told you, I will tell you why there is muscle in between glands and Peutz-Jeghers polyp, right? Can anyone help me in saying that what is the gene mutated in Peutz-Jeghers syndrome or Peutz-Jeghers polyp? The gene mutated, we have STK11 and LKB1, right? Or LKB1, this is a gene mutated. Peutz-Jeghers syndrome, it's a inherited syndrome, so this gene has to be a tumor suppressor gene, right? So this gene is tumor suppressor gene, but it has two roles. One is obviously to suppress cell division. The second one, the normal function of the gene is to maintain polarity. Maintain polarity, especially in the GIT. Okay. To some extent in other tissue as well, but main function is to maintain polarity, right? So we have to understand what is polarity in order to understand the microscopy and other features of Peutz-Jeghers syndrome as well, right? Let's say polarity is, if I take a normal histology of an intestine, the topmost layer is mucosa, submucosa, muscularis propria, serosa, right? That is polarity. If you take a normal intestine, I'll have mucosa, submucosa will be there, then I'll have muscle here, then I'll have serosa here, right? That's my normal polarity of an intestine. So who maintains that is STK11. And I said that it's a tumor suppressor gene. If it is a tumor suppressor gene, what mutation should cause the cancer? Gain of function mutation or loss of function mutation? We know about tumor suppressor gene and proto-oncogene basics. Gain of function or loss of function? It has to be a loss of function mutation. Perfect, right? So let's assume a patient with a Peutz-Jeghers polyp or a Peutz-Jeghers syndrome is not having STK11 or LKB1, right? Which means there is no tumor suppression, so it grows automatically, and also there is no one to maintain polarity. They can't maintain polarity. When they can't maintain polarity, can I say that a muscle which is supposed to be very low now don't know where to go, because I don't have someone to say that, okay, you go below submucosa. So what happens? The muscle comes inside my mucosa. That's the reason I am having muscle in between the mucosa. When the polarity cannot be maintained, the muscle kind of goes between the layers of the glands. That's a mucosa, fine. So that's why the microscopy image is like that. Again, it's due to the pathogenesis. We can actually extrapolate this to a very, very beautiful finding as well. If I tell me one clinical manifestation of Peutz-Jeghers syndrome, what comes to your mind first? In case of Peutz-Jeghers syndrome, one clinical manifestation. There's a spotter. You must have seen that in dermatology as well. Anyone? We'll make it more awesome, Samrat. Perfect. Pigmentation, right? Superb. So I'm going to take whatever you said, and we're going to apply the same concept. If you exactly remember, it will be oral mucocutaneous hyperpigmentation. It will be in the oral cavity and maximum in the lips and around the lips predominantly, because as I said that STK11 is responsible for maintaining the polarity in the GIT. Is oral cavity also GIT? That's also part of a GIT, right? It's still a part of GIT. But in oral cavity, I don't have my columnar epithelium, I have squamous epithelium. So for maintaining polarity of squamous epithelium is simple. The lowermost layer should be stratum basal, the topmost layer should be stratum corneum. That's maintaining polarity. For that, STK11 helps me. In Peutz-Jeghers syndrome, STK11 is gone. So can I say a cell like a melanocyte, which should ideally be in stratum basale, now don't know where to be? Yes. So ideally a stratum basale is where my melanocyte should be there. When STK11 is gone, it comes on the top. It not just comes on the top, it's tumor suppressor gene, slightly increased growth as well. So can this cause the melanocytes in, let's say in the stratum spinosum or granulosum with little bit increase in the proliferation, can it cause hyperpigmentation? It will cause hyperpigmentation, right? Definitely cause it. Again, the oral mucocutaneous hyperpigmentation is also due to the pathogenesis. It's STK11, LKB1, which helps in the maintaining the polarity and also the tumor suppressor effect, which gives the classical finding of Peutz-Jeghers syndrome. One of the important cancers which any person with the Peutz-Jeghers syndrome should be aware of is your pancreatic cancer. It said that the risk is close to 100 times more, right? Risk is close to 100 times more for pancreatic cancer in case of Peutz-Jeghers syndrome. Okay, it's fine, Samrit. As you're very young still, you have lots of years to read. For every one of you, when you become postgraduates, nothing is a fact. If it is a fact, it is idiopathic. If it is not idiopathic, and if the book doesn't say it's an idiopathic, which means I have to go and read what is the reason for the fact, right? You will read for sure. Definitely, you will become much more better. When you read more things in future, do share it with me. Don't miss me. Don't leave me just hanging. Learning is always mutual. We have to learn till we are alive, fine? Okay, let's go to the next image. The algorithm is same for me. Are you seeing villi or not? Are you seeing villi or not? There are no villi here, right? So if there is no villi, next question. Are you seeing muscle between the glands? Again, there are no muscle between the glands, right? So in other words, I'm having glands. The glands are dilated or smaller. Majority of the glands here are smaller glands, right? There are smaller glands. The algorithm is simple. Add no villi, no muscle, just glands, and they are smaller glands. If it is not dilated glands, if it's smaller glands, my diagnosis is simple. It has to be an tubular adenoma. Okay, just has to be tubular adenoma, right? So you can easily differentiate the colonic polyps just by the algorithm. Fine. Villi, muscle, glands, small glands, tubular adenoma, dilated glands, your juvenile polyposis. Fine. Okay, next image. Here, are you seeing villi or not? Is there any villi here? Definitely there's lots of villi. Can I say that almost the entire polyp is full of villi here? I'm having the stalk of the polyp here, right? That's a stalk. Don't mistake that for muscle between the glands. Almost everything here is a villi. It's a finger-like projection. Almost. Maybe this corner I can see a gland a little bit, maybe a little bit, but definitely more than 75% is villi only. Again, as I said, that this is stalk of the polyp. Don't mistake it for muscle between the glands. Fine. It's completely villi. So this is how a villus adenoma will look. For an undergrad at least, I will give you, the examiner should give you a very classical villus adenoma, which is easy like this, right? Complete villi, villus adenoma. Fine. Next. When you look at this villi, this is also a villi. I'm sure that you will appreciate that this is definitely a villi, right? In this villi, and I'll just try to draw something. I'm just drawing the outline of the epithelium of the villi. There's a dip here. I'm just going here. Again, there is a dip. I'll go here. Again, there is a dip here. It's subtle dips here, right? So can I call this serrations? Does it look like serrated? It's a villi for sure, but definitely there are subtle dips here and there. That's how serrations look like, right? So serrations are a bit difficult. Serrations will be easy when I draw it. If I remove the drawing, serrations is really difficult for an untrained eye to pick it up. Fine. I'll just remove the drawing for a second. It doesn't look like a serrated lesion at all. So serrations is one of the findings for serrated adenomas. As I said, the other finding is very easy for us to pick up. The second finding is this. Let's look at this. If you remember your crypt and a villi, your villi will be on the top, crypt will be like this, crypt of Libacon, right? Crypt and a villi. Can I say that all the crypts in the intestine will be U-shaped only? Undoubtedly, yes. Crypts of intestine should be U-shaped, right? So if a crypt is not U-shaped, for example, this crypt looks like a T. It's definitely not U-shaped. This is how a distorted crypt looks. Okay. If you have a crypt which is not U-shaped, I call it a distorted crypt, right? Boot-shaped crypt if you want to call it, fine, whatever shape you want to call it. It is not U-shaped, I call it distorted crypt plus serrations. My diagnosis is serrated adenoma, fine. I hope you should not have any more difficulties in identifying colonic polyp. The algorithm is very simple. Look for villi, not there. Look for muscle, not there. Gland, dilated, your juvenile, not dilated tubular. Muscle between the glands, Peutz-Jeghers. Villi, villus adenoma. If nothing there, keep a serrated adenoma. Fine. Maybe keep serrated adenoma as a diagnosis of exclusion. Still, you'll be able to pick them all up. Fine. Okay, great. Okay, AFSA, how to identify a hyperplastic polyp? I don't have an image of hyperplastic polyp, but definitely I'll tell you. See, the hyperplastic polyp is one thing is history will help me. It's a very, very incidental finding. It's a polyp which can be 0.5 centimeter. That's all. It's mostly seen in old age or a person who has an ulcer, like a peptic ulcer disease. That history should be there, fine. So what I see in hyperplastic polyp is, like I said, that we'll go with the pathogenesis. Then we'll be easily able to extrapolate what I'm going to see in the hyperplastic polyp. One of the thing is there is a peptic ulcer in stomach which can cause an hyperplastic polyp. Second is old age. Old age, any tiny, very tiny traumas. A response to the trauma, there is a little bit increase in the hyperplasia of the epithelium. That's what is the reason for hyperplastic polyp. In peptic ulcer also, the response to injury has a tiny increase in the size of the mucosa, which results in hyperplastic polyp, right? If you remember any of the colonic mucosa, right, or even the gastric mucosa for that matter, what do you see in the topmost layer? If it's colonic mucosa, what cells is predominant in the epithelium? Can I say that it is predominantly formed of goblet cells? Almost every other cell in my intestinal epithelium will secrete mucin, right? They'll be predominantly goblet cells. So when I have hyperplasia secondary to injury, what I'll have is there'll be lots of goblet cells. I'm sure you'll be able to pick up a goblet cell. If you see fully goblet cell in a biopsy which says it's a polyp, it's an hyperplastic polyp. And almost there will be nil dysplasia. There'll be no hyperchromasia, nothing. It's just filled with goblet cells because in response to an injury, goblet cells becomes predominant here, fine. That's the easiest way to pick up hyperplastic polyp. I'll try to share the image in the group of an hyperplastic polyp, fine. Okay. Any other roles in colonic polyps? No. Okay, if there are no other doubts, we'll have a little bit of questions. We'll cover the questions, whatever I wanted to cover in GIT. We'll cover that and we'll call it a day, fine. Okay, the first thing is this. I'll mute myself for 30 seconds. Comment on the answer. I want everyone to comment the answer. It's a very, very simple question. Answer. Yes, Hafsa. Inflammatory polyps looks the same like an hyperplastic polyp. Okay, option D, right? Great. It's almost like a classic case of celiac disease. The only thing is the bro food is not there here. It's a classic case of celiac disease, right? A 7-month-old kid brought to the pediatrician, had a past 2 weeks of irritable, lost 2 kg of weight and diarrhea. The mother reported she was breastfeeding the baby until 3 weeks back, and they introduced formula feed into the diet. Following symptoms is due to what mechanism, right? See, Since I don't have an history of bro foods, that's very important to call celiac disease. I don't have the history, so obviously I have to go to this question in a retrospective way, try to rule out the other things. Aganglionosis of colon. What disease are we talking about? What disease are we talking about? Hirschsprung's disease, right? Perfect. Hirschsprung's disease is not going to present like a diarrhea after introducing formula foods, right? So Hirschsprung's disease might present in the neonatal time, like not passing meconium. That should be the commonest finding on Hirschsprung's. It's not going to be related to this. Since we are in Hirschsprung's, can any one of you comment any one gene which is involved in Hirschsprung's disease? I'm sure you know at least one gene involved in Hirschsprung's. Mutation of one gene which can cause Hirschsprung's. Red proto-oncogene mutation can cause Hirschsprung's. Gain of function or loss of function? Gain of function or loss of function? Hirschsprung's, it is loss of function, right? In your Men's syndrome, which also is related to red proto-oncogene, there it is gain of function. In Hirschsprung's, red will have a loss of function, right? It's a proto-oncogene. If it's going to cause cancer, I'll have a gain of function. Here there's a loss of function here, fine. Okay. Hypertrophied muscle in the pylorus of stomach. What disease are we talking about? This is a famous question in pediatrics. I'm sure you know the answer, right? It's an pyloric stenosis, right? Congenital hypertrophic pyloric stenosis. The patient is not going to present like this, might have a projectile vomiting and a mass in the epigastric region, olive shaped mass to be specific, and they also present very early in life, right? So unlikely to be the scenario, we'll rule it out. See, absence of smooth muscle in the wall of the duodenum, it's a very non-specific finding. When smooth muscle is absent in any part of the duodenum, only thing I can have is a diverticula, because muscle is something which is very strong, which can result in diverticula. So again, it's not going to have the symptom of flatulence and loss of weight after introduction of it, fine. Okay, and obviously the only thing which fits in here for celiac disease is anti-gliadin antibodies, right? We have discussed celiac disease quite a few times, right? So celiac disease, again, I'm just going to ask a few questions that have been repeated in celiac disease. I want you guys to answer. What is the HLA which has association with celiac disease? HLA association in celiac disease. There are two HLAs. HLA DQ2 and DQ8, right? Both of these two HLAs are predisposed to celiac disease because these are the HLAs where if this MHC molecule is there, the gliadin, the deamidated gliadin can be picked up and my MHC, my antigen presenting cells can get triggered. That's why these two HLAs are very important, DQ2 and DQ8. Other HLAs will not recognize the deamidated gliadin as a foreign body. It will just be left, it will not react to it. That's the reason these two HLAs are very important, fine. So that's one. Second, is biopsy or an colonoscopy required for the diagnosis of celiac disease? Yes or no? Do we need that for diagnosis? Is biopsy mandatory for diagnosis? Definitely no, right? Biopsy is something which is never required in case of celiac disease, but unfortunately still there are people who do biopsies for celiac disease. That should never be done, right? When there is an antibody, I can easily do an antibody, right? So anti-gliadin antibody, anti-tissue transglutaminase antibody, anti-TTG antibody, and obviously other one is anti-endomysial antibodies, right? I'm definitely not contemplating which is best, which is more sensitive and more specific. I will leave it to your medicine faculty. If they think that this is important, they can go ahead with that. The simple reason being that this percentage of sensitivity and specificity is very minimal. One is 97, 98 and 99. Doesn't matter at all. It's anyway going to give me the diagnosis. TTG is the one which is commonly available in the lab. Even if you write endomysial, I will do TTG only because I don't have endomysial, right? So TTG is easily available. I'm going to use this, fine. So this here, since it's an antibody mediated disease, I'm kind of going to take a detour and learn one important concept which is very important for you to avoid few mistakes. In celiac disease, what do you think is a cell which destroys the intestinal epithelium? T lymphocytes or B lymphocytes? T cells or B cells? Which destroys the epithelium in celiac disease? It's undoubtedly T lymphocytes, right? So if I have to push into hypersensitive reactions, will it be type 2 hypersensitivity or type 4 hypersensitivity? Though it's not pushed into hypersensitivity reactions, if I have to push it, type 2 or type 4, it should be kind of type 4 hypersensitivity, right? But I do have autoantibodies present here as well. That's how I diagnose celiac disease with anti-gliadin antibodies. If you have any disease with autoantibodies, what will you think first, type 2 or type 4? If it's antibodies, we'll think of type 2 first, right? So, but don't do this, because for quite a few lesions, which is type 4 hypersensitivity, over the period of time, antibodies will definitely be created. That is actually not the pathogenesis. That's the outcome of the pathogenesis. So what happens here is, the function of tissue transglutaminase is to convert gluten to gliadin. So what my body does is, I have to prevent celiac disease. So my body produces antibodies against TTG, destroys TTG. So no more gluten will be converted to gliadin, or destroys gliadin, so that I don't have anyone to trigger my APC, so that it reduces inflammation. So type 4 T cell mediated destruction, which produces autoantibodies. This is useful for diagnosis, that has no role in pathogenesis. Why this is important is, let's take diabetes mellitus, type 1 diabetes mellitus, or an insulin dependent diabetes mellitus. Is it type 4 hypersensitivity or type 2 hypersensitivity? Insulin dependent diabetes mellitus, it's in type 4 hypersensitive reaction. It's not a type 2 hypersensitive reaction. It's precisely the reason why I wanted to remember this, right? Because again, insulin dependent diabetes mellitus is a T cell mediated destruction. If it is T cell mediated destruction, I will have antibodies to GAD. That is a response to the destruction, not the cause of the destruction, right? The response to the destruction doesn't make that type 2 hypersensitivity, it is type 4 hypersensitivity. Don't mistake this and write a type 2. You can go to Robbins, you'll have a table in the Robbins. Insulin dependent type 1 diabetes is type 4. Even when I have autoantibodies, it's going to be type 4. Fine. Same goes true with Hashimoto's thyroiditis. Same goes true with your pernicious anemia. Everything starts as T cell mediated destruction. After that, I'll have antiparietal antibodies in pernicious anemia. After that, you'll have your antibodies to thyroid peroxidase in Hashimoto's. The starting point of pathogenesis determines what type of hypersensitivity it is, not the end point. Fine. Always remember this. Don't get confused in this. Fine. Okay, great. So if it is a T cell mediated problem, a patient with a chronic celiac disease, not able to stop the bro foods, still continuing the bro foods. Okay, still continuing the bro foods. What is the risk? What is the long-term risk of this patient? Aishwarya, the list of the disease is there in Robbins. Maybe I'll share the screenshots of the tables in Robbins. If you have that, that will be great. If you can cover that, it will be easy for you to remember. Okay, what do you think is a long-term complication of celiac? It's a T cell lymphoma. Again, reiterating the point that T cell is the one which is important in the pathogenesis, not the antibody producing plasma cell or B cell, right? You have a very severe lymphoma. It's an enteropathy associated T cell lymphoma which causes the disease. Fine. Okay, it's important. Do remember that. Fine. It's a lymphoma with not such a good prognosis. Patient don't live for a long time in that case, right? Okay, we'll go to the next question. Read the question, we'll see. I'll mute myself for 30 seconds. I want everyone to comment the answer, then we'll discuss. Samrit, if I have to push into hypersensitive reaction, I said I will push into type 4. It's an inflammatory condition where it is not classically defined as an hypersensitive condition. Fine. Okay, Pratmesh has gone with D, Prithvi has gone with D. Anyone else wants to add to it? D. Okay. Fine. The only thing here for me is why it is not a pernicious anemia. Can anyone tell me why you went for urease production and not with antibodies to intrinsic factor? Almost everyone went for urease production. Okay, great. That's very important. The number of parietal cells is not significantly reduced, right? If the parietal cells is not significantly reduced, it can never be an antibodies to intrinsic factor or antibodies to parietal cell. In case of an pernicious anemia, that's like almost 100% destruction. It's almost 100% destruction in case of a pernicious anemia. That's also atrophic gastritis. Am I right in saying that even in pernicious anemia, I will have lymphocytic infiltration in the gastric mucosa with mucosal atrophy? The same will be the scenario in case of an H. pylori gastritis also. The only difference is the quantity of parietal cells. If there is no parietal cells at all, I'll think of a pernicious anemia. There is a little bit of parietal cells left. My first possibility is an atrophic gastritis, type A or type B in this condition. This a classical description of an atrophic gastritis. You're going to say it's type A or type B. Type B atrophic gastritis, right? H. pylori is type B, and obviously your autoimmune gastritis is a type B atrophic gastritis, right? Great. Okay. So if it is in type B atrophic gastritis, my important thing is going to be H. pylori, and one of the mechanisms of the disease process is urease production. Urease is important for pathogenesis. Some of you commented achloridria. What is this significance of achloridria and H. pylori? Is there any significance first? If so, what significance? Can I say that achloridria will kind of predispose to H. pylori infection? There is a little bit less of acidity in the stomach, so H. pylori can easily live there for a longer time. Is that and it can easily reproduce, right? Little bit less defense mechanism. Achloridria will predispose to the infection even with a lesser dose of H. pylori. It's not going to cause your disease process. It's not important for the disease process. It's just a risk factor. On the other hand, urease is the one which reduces the local pH. Once a local pH is reduced, it kind of survives more, it divides more, it penetrates and causes an ulcer and inflammation. Fine. Urease is very, very important for the pathogenesis. Apart from urease, you have flagellin, which is one of the things which helps the H. pylori to get adhered to the mucosa, and your there are a few more factors as well. Can any of you name any few genes involved in H. pylori? A few classical genes. I'm sure you remember the genes. One at least you should never forget is CAG. Right? CAG and VAC. CAG don't forget at all, because CAG is one of the important things which is responsible for the H. pylori induced cancer as well. It's cytotoxic associated antigen, right? CAG is important for the cancer pathogens also. Fine, great. Okay, read the question. I'll mute myself for 30 seconds. Let's see. Answers? Okay, somebody has gone C. Great. A good one, an easy one, I suppose. Okay. Just one question. I think the biopsy revealing a spindle cell with a vacuolated cytoplasm is diagnostic of GIST, right? This vacuoles in the cytoplasm and spindle cell is almost diagnostic of GIST. The only thing which I want to ask you here is not the IHC. I'll come to the IHC, which everyone knows. Gist is a tumor arising from the mucosa or submucosa. Gist arises from mucosa or submucosa. Gist arises from stroma, right? It's a submucosal growth, right? The stromal growth is in submucosa, right? If it is a submucosal growth, how can you explain this particular history? It's in the stroma, which definitely is submucosal. How can you explain the patient had a tarry stool? If it's a mucosal growth, ulcer can be explained. How can you explain the tarry stool in case of this particular person? Perfect, right? It's a pressure necrosis, right? So what happens here is, let's assume this is my epithelium. I'm having such a huge gist in the submucosal location. Obviously, this can cause pressure-induced necrosis, right? So it's the pressure which might cause the necrosal atrophy, and definitely it can go to, the diagram in the Robbins will help you for it, right? So the pressure atrophy can cause it. So keep in mind that if you have an mucosal ulcer or a bleeding, it's not always epithelial lesion. If it's a stromal lesion, if it is big enough, it can still cause pressure atrophy, it can still cause ulcer and cause your melena or a tarry stools, fine? Classical condition of gist, okay? I am sure that you know the IHC protocol for gist, what to do. Pratme is said to be an artifactual finding, the vacuole. We're not able to identify why it's a vacuole there, because in an FNAC it's not seen. It's like your orphan Annie nuclei, a formalin-induced artifact which gives the vacuole in case of a gist. It's not seen in all the gist. In an epithelial gist, you may not see it. In a classical gist, it will be seen. At least for undergrad, it will be seen. Right? Okay. The protocol is simple. The first thing to do is obviously CD117. Only when it's negative, we use Dodge1. If Dodge1 is positive, definitely I'm going to call it gist. This makes Dodge1 a very, very specific marker, and CD117 obviously the most commonly done marker. The expansion of Dodge is discovered on gist first. Right, few things you can never forget. That's there in the explanation as well. It's not my expansion, it's not a mnemonic. That's how the IHC was named. It's discovered on gist first. That's why we call it DOG1. Right? Okay. If I say that this is very, very specific, I'm sure all of you know this thing, right? Prathamesh will come to SDH. If I say something is very specific, why don't I do it first? Why do I still do CD117? It's not very expensive Dodge1, almost on the same account. Expense might not be the only reason, but why do I do CD117 still, even after knowing Dodge1 is very, very specific? Anyone? Perfect. Treatment, right? So pathology is not just for diagnosis. Pathology is more for prognosis, and about diagnosis as well. If I have c-KIT positivity, I can tell to the treating physician or a surgeon that okay, c-KIT is there, so I can give imatinib to gist. If I directly dump to Dodge1 without doing CD117, I cannot give that information to the person, so I'm missing out on very important finding, which is imatinib sensitivity. Because of that only CD117 or c-KIT is very, very important. Even though Dodge1 is specific, I'm not going to do it first. I'll still do CD117 only. Fine. Prathamesh, coming back to you, SDH is a mutation. It's not an IHC. We do have SDH deficient gist. SDH is succinate dehydrogenase, which comes under oncometabolism, right? So loss of SDH can predispose to gist, can be a sporadic association, or can be a syndrome. In a Carney-Strackes syndrome, you'll have a mutation in SDH which is transmitted in an autosomal dominant fashion. Fine. Okay, do remember this as well. Fine. Okay. Try to answer this question. It's an interesting one. Few seconds. Answers. Okay, B predominantly B and a little bit of A. Chakravarti, coming back to your question, when to give imatinib, there are protocols to give imatinib. The surgery protocols will help you, or the medicine protocols will help you. But imatinib can be used for GIST, especially to reduce the size of GIST pre-surgery if it's very, very huge. Fine. Okay. So either it's apoptosis or necrosis, right? It's ingestion of something, acute distress, swallowed a strong acid. So it's definitely a pathological condition. Acid will definitely burn a tissue. Right? If acid burns a tissue, this can never happen, right? I cannot have an acid acting on a skin, destroying a skin without losing the plasma membrane or without losing the cell membrane, right? So apoptosis is not possible in such a high grade, in high intensity pathological condition. So it has to be necrosis only. And the necrosis, the tissue is my esophagus. If it is esophagus, it's not going to cause an sclerosis. It will not cause an fat necrosis. It's an epithelium. So epithelium almost always dies with coagulated necrosis only. It's not that always infarct is the only thing which will cause coagulated necrosis. Most of the injuries will cause coagulated necrosis only. When I fall down, that also will cause coagulated necrosis in the skin, right? So it's not just the infarct. There are multiple places where coagulated necrosis is important. That's the only thing, learning point from this question. Multiple things can result in coagulated necrosis. Fine. Okay. This is a simple one. 30 seconds. That might not be required. Answer the delicate answer. Pratmaya, alkaline injury is more of a chemical reaction, which again produces an exothermic reaction which destroys all of them. It's anything pathological will be necrotic only at the end of the day. What triggers necrosis is what is going to get differentiated, right? It's a classical case. Thank God you say Samrat. So it's a classical case here. What is the stain used here? The stain used here is, like the question says, that there are two different types of silver stain. It could be either Steiner silver stain, or I can use Warthin-Starry. Okay. I can use Warthin-Starry or a Steiner silver. Its base is more important. What is the procedure differentiate between Steiner silver and Warthin-Starry? And here all the black particles here in the mucosa, in the lumen is your H. pylori. Fine. Aishwarya Srinivas, liquefaction necrosis is seen in a very, very few places. One of them is your CNS infarct. Abscess cavity, you see liquefaction necrosis, and you bite gangrene. Very few places we see liquefaction necrosis. Fine. If it's H. pylori, just now we saw that your cytotoxic associated gene A, the CAG A, is very, very important for the pathogenesis of this condition. Okay, great. Let's see one or two questions if it's okay on liver. At least one. We'll start with tomorrow in liver in your 7 p.m. class. So I just want to kickstart it here. I'll mute myself for 30 seconds. Comment on the answer. Great. It's a neonate, right? Neonate with persistent jaundice despite aggressive chemotherapy and exchange transfusion. Okay, I wanted to ask the question, Pratmaya Kumar, like, is it type 1 or type 2? Or type A or type B, whatever you want to call it. It's a neonate with a very, very severe condition. So it has to be almost like a nil quantity of your UDP glucuronide transferase. So it has to be your type 1 Crigler-Najjar syndrome, right? Type 2 will not present during neonatal life. Type 2 will take its own sweet time because type 2 is not zero enzyme activity, it is reduced enzyme activity, right? The kids can grow, they'll have icterus, but not requiring your aggressive phototherapy or exchange transfusion. And it says that it's total absence. When it's total absence of glucuronide transferase activity, definitely it is type 1 Crigler-Najjar only, fine? Okay. What gene is mutated in Gilbert syndrome? Pratmesh, phenobarbital effects is on type 2 Crigler-Najjar because an enzyme inducer. UDP glucuronide transferase is also an CYP enzyme, one of the subtypes of CYP enzyme. So when I give phenobarbital, it will definitely elevate the activity. So the type 2, where there's a reduced glucuronide HR, can be compensated. Right? So what gene is mutated in Gilbert syndrome? Gilbert is also UDP glucuronide transferase only. The mutation is different, that's all. In glucuronide HR, there's a quantity problem. In Gilbert, what happens is you will have a mutation in the same UDP glucuronide transferase. Okay. The only thing in Gilbert syndrome is there's a mutation in the Tata box. You must have heard about Tata box, right? So Tata box is where the Tata box component of UDP glucuronide transferase gene gets mutated in Gilbert syndrome, which means the promoter sequence is disturbed, so there's a disturbance in the production of your enzyme. Fine. MRP2, since you've taken it some breath, where will you have mutations in MRP2? Which disease? Tata box minus 35%. I'll leave it to you, biochemistry professor. MRP2, multi-drug receptor protein 2 mutation is seen in Dubin-Johnson syndrome, right? In case of a Dubin-Johnson syndrome, you'll have your MRP2, multi-drug receptor protein 2 mutation in Dubin-Johnson syndrome. Fine. Okay. We'll call it a day here. Rotar will have your anion exchanger protein mutation. It will not be in MRP2. Fine. Okay, great. Fine. So what we'll do tomorrow at 7 p.m. is we'll kickstart with liver in the Unacademy app. Try to cover liver and gallbladder questions. So hopefully by the middle of next month, we should be able to finish the first round of revision. Second round, we'll have mixed bag. Mixed bag will be a little bit more interesting because you don't know what subject we are dealing about, right? Just press me. If you have any doubts, you can let me know. What's it out? Can you first tell me what does SBP means? Some of the abbreviations which I might not be able to remember. Okay. I don't think so. There's a test called single base pair examination. There are multiple tests which comes under that. I think PCR can detect single base pair problems. Your Sanger sequencing can detect single base pair problems, right? See, the answer lies in your question itself. Fish can never target a single base pair, right? Fish can always target a chromosomal anomaly. If I'm having like a translocation, I'm having like a trisomy or a monosomy or a deletion, fish can target that. Fish can never target at a genetic level. The test is not just based on what we know, what you're going to look for. It's for chromosomal anomalies or an amplification of attenuates at the genetic level. Because in a fish, I use a normal microscope, fluorescent microscope, but still a normal microscope's power only. I cannot look at the gene level. But when you take a single base pair examination, my PCR can detect it. It can detect a point mutation, or I can do a Sanger, which can detect a point mutation, right? So it's not just the disease what you know. For example, when I take Marfan syndrome, I'll have a mutation. I cannot do a fish there. On the other hand, in case of a CML, I have to do a fish because of translocation. I cannot do a single base pair examination there to identify mutations, right? So it's also based on what is the genetic problem. Based on that, we'll decide the test. Fine. Is that clear? Okay, great. Fine. If there are no other doubts, we'll call it a day. Just a quick update again. If you have the Unacademy app, the way to go with the PYQ thing is go to the test section. You'll have multiple subjects here. You can go to any one of the subject and you go there, there'll be a PYQ previous year questions. I hope you'll be able to access that. We uploaded quite a few, and many will be on the way before your exams. Fine. Okay, thank you for your time. See you tomorrow with liver, and hopefully we'll learn more together. Fine. Thank you. Bye bye. If you have any doubts at any point of time, you can contact me. Good night.